A quick hello before we dive in. My name is Dr. Michael, a practicing GP here in Auckland. I help international medical graduates prepare for the NZREX clinical exam through focused OSCE tutorials. My sessions include small group practices and personalized one-on-one mock exams with detailed and practical feedback to help you build confidence in communication, clinical reasoning, cultural safety, and managing those time stations. If you're on the journey towards registration and practicing in New Zealand, you're in the right place. You can find more information about my courses and upcoming sessions on my website. Let's get started with today's topic. So in today's topic, we're going to be talking about headache. Headache is one of the most common symptoms seen in general practice or emergency settings in the hospital. Most of the headaches are benign, such as migraines or tension-type headaches. However, the key challenge for clinicians is recognizing the smaller number of headaches that represent serious or potentially life-threatening conditions. So when we approach headache cases, the goal is not simply to diagnose migraine or tension headache. The real goal is risk stratification to identify the red flags early while recognizing patterns that are more likely to be benign. The safest approach is to begin with a structured pain history using the mnemonic that we talked about, Socrates, S-O-C-R-A-T-E-S. So the main consultation structure starts by an introduction, to greet yourself to the examiner, and to greet yourself to the patient. I'm Dr. Michael, I'm one of the doctors here today. Could I confirm your name and age please, to confirm the identity of the patient? So thank the patient and start by asking an open question. What brings you here today? At this stage, I allow the patient to speak freely. This is the golden 60 seconds. We're gonna get all the important information from the role player. This is important because patients often reveal critical clues early. For example, if the patient immediately says, "This is the worst headache I've ever felt," or "It came on pretty suddenly, I never had this before," those statements already raise concerns for serious causes. Once the patient finished describing the problem, I move into a structured pain assessment. So I start by exploring the presenting complaint, which is Socrates' framework. Where exactly is the pain? The location can provide very useful clues. Migraine are often one-sided, tension headache are commonly described as a band around the head, and sinus headache may cause pain around the face or the forehead. However, location alone is never diagnostic, so it must always be interpreted together with other features. Onset. When did the headache start? Did it come on suddenly or did it come on gradually? This question is extremely important. A headache that reaches maximal intensity within seconds may suggest something we call subarachnoid hemorrhage, which is a medical emergency. Gradual onset headaches are far more commonly benign. Characters is also important. How would you describe the pain? For example, is it a dull pain? Is it throbbing pain? Is it sharp or is it pressure-like? Patients often struggle to describe the pain, so giving examples help them explain it more accurately. Throbbing headaches often suggest migraine, while pressure-type headache often is commonly seen in tension-type headaches. Radiation. Does the pain go anywhere else or does it stay in one place? Some headaches radiate to the neck or behind the eyes. Understanding that radiation pattern may help distinguish different headache types. Timing and pattern. Is this the first time you've ever had this type of headache? Have your headache changed recently? This question helps us detect the pattern change, which is an important warning sign. A completely new headache, particularly in older patients, may require further investigation, which is also a red flag. Similarly, if a patient with known migraines describes a headache that feels different from their usual pattern, should arise concerns. It's important to know about the exacerbating and relieving factors. Is there anything that makes the headache worse? For example, movement, bright light, coughing, or bending forward. These questions help identify triggers. For example, headache that worsens when bending forward may suggest sinusitis, while headaches worsened by coughing or straining may suggest raised intracranial pressure. Does anything make it better, such as resting, sleep, or medication? Migraine often improves in a dark, quiet environment. Severity. On a scale of 0 to 10, how severe is the pain? This helps assess the level of distress and functional impact. However, it is important to remember that severity alone does not determine whether a headache is dangerous. It's important after exploring the presenting complaint that we go through our differential diagnosis screening. After understanding the pattern characteristics, the next step is targeted screening for serious or common causes. So for migraine, we can ask questions like, do you feel nauseated during headache? Are you sensitive to light or sound? Do you experience visual symptoms before the headache starts? These questions screen for migraine features. visual disturbances such as flashing light or zigzag signs are also known as migraine with aura. Tension type headaches. Does it feel like a tight band of pressure around the head? Does it usually happen after stress or a long day of work? Tension headaches are commonly associated with stress and muscle tension and usually relieves after the patient has a good rest. Sinusitis is a common cause of headache. Do you have any facial pressure? Any blocked nose recently? Any history of rhinitis? Or any green or yellow nasal discharge? Or any pain around the face when you bend forward? Subarachnoid hemorrhage is a medical emergency. Did the headache come on quite suddenly? Patients usually describe these type of pain as the worst type of pain they have ever felt. It's like a 10 out of the 10 pain, which is what we call a thunderclap headache. And this requires urgent medical attention, and usually we send the patient to the ED right away. Meningitis is also a red flag. Have you had fevers, any neck stiffness, any rash around the body, any sensitive to bright lights? These questions screen for meningitis. Travel history is important, or recent infection may also provide some clues. Joint self-arthritis is also a medical emergency. For patients over 50, I always ask, do you have any scalp tenderness, any scalp sensitivity when you touch the scalp, any jaw pain when you chew food, or any recent vision changes? Joint self-arthritis is important to recognize early because untreated cases can lead to permanent vision loss. So after going through the differentials and trying to rule out the red flags and the urgent conditions, we go back to the P. maculosa, the mnemonic that we talked about, to explore the background history. So I say, next, I briefly explore the patient's medical background. Have you ever been diagnosed with migraine or similar headaches before? Are you currently taking any medications, including pain medication or using any contraception? Do you have any allergies to anything? What do you do for work or study? Occupational stress, prolonged screen exposures, or poor posture may contribute to headaches. Are you currently under any sort of stress? Who do you live with? I also consider lifestyle factors such as sleep patterns, alcohol intake, smoking, hydration, and caffeine use. Now, once P. maculosa is explored, we want to know about the eyes, ideas, concerns, and expectations, which are very important if you want to get a good score. What do you think might be the cause of these headaches? Is there anything particular that you're worried about? If the patient said, I'm particularly worried about a cancer, doctor, then you want to further ask, why is it that you're worried about a cancer? What were you hoping for that I can help with today? Many patients worry about serious conditions like brain tumors, so exploring their concern is very important. Now, the social aspect to explore the effect on the daily life. How has this headache affected your daily life? Has it affected your work or studies? Has it disturbed your sleep? Understanding functional impact helps guide treatment decisions and also help build your rapport. Now, after history taking, you want to do a physical examination. So I always thank the patient, thank you so much for telling me all this information, it was really helpful. I would now like to check your vital signs. Perform a brief neurological examination, including looking at the back of your eyes, because fundoscopy is important. Swelling of the optic disc, known as papilledema, may suggest raised intracranial pressure. If the examination is normal, I reassure the patient, your examination today is reassuring. But based on your symptoms examination, this appears most consistently with migraine. Have you ever heard of this diagnosis before? No, doctor. A migraine occurs when the brain becomes temporarily sensitive to certain triggers, leading to headache along with symptoms such as nausea and sensitivity to light. Does the explanation make sense to you? Now, moving on to management plan. Management always depends on the underlying diagnosis. If the presentation is consistent with a primary headache, such as migraine or tension headache, treatment usually focuses on symptom relief and trigger management. This may include appropriate pain relief such as paracetamol, ibuprofen, taking early when symptoms begin. For migraines, specific medications such as triptans can be considered. Lifestyle advices is also very important. Many headaches are triggered by dehydration, poor sleep, skipping meals, alcohol, or stress. So patients are encouraged to maintain good hydration, eating regular meals, having good sleep, stress management. If headaches are frequent or disabling, preventative medication may be considered. However, if red flags are present, like the red flags that we talked about, management changes completely. For example, if subarachnoid hemorrhage is suspected, the patient requires urgent hospital assessment right away and also further imaging. If meningitis is suspected, urgent antibiotics and hospital care are required. Again, the same. For joint self-arthritis is suspected, steroids should be started immediately to prevent vision loss. So the key principle in headache management depends on recognizing which category the patient falls into. Is it benign primary headache, secondary headache requiring investigation, or emergency headache requiring immediate action right away? Always finish off the case by safety netting. Tell the patient if anything changes, such as sudden severe headache, confusion, vomiting, weaknesses in your arms or your legs, or any changes in your vision, please seek urgent medical care immediately. Always organize a follow-up with the patient. Let's review this again if the headache becomes more frequent or changes in pattern. We can always offer the patient to keep a symptom diary to see the frequency and the pattern of their headache. So once in review, you can have a more discussion. Also provide the patient with some leaflets to summarize the key points that we discussed today and about specific diagnoses such as migraine so that they can understand the diagnosis a bit more. So I hope this episode has helped regarding approach to headache cases, and I look forward to seeing you in the next episode.